Hi, everyone. I'm Dr. Diana Bitner with True Women's Health, and we're here for our frequent episode of Let's Chat. So tonight we're going to let's chat about pelvic pain. As you all know, I'm very much interested in wellness and supporting women with healthy aging as they age. And so we don't always talk about specific problems such as pelvic pain, but we just feel that this is so important to address. Not only was it recently Ovarian Cancer Awareness Month, but it's just such an important part of women's health. And I care about this because I believe all women deserve to age without unnecessary suffering. And, you know, a picture is worth 1,000 words. So you saw that first picture that we used to talk about this event, pelvic pain. You see the woman curled up in fetal position. And that's what pelvic pain is. It's that isolating pain that oftentimes women don't know what's causing it. They don't know why they're suffering, but it limits their lives. And women who suffer pelvic pain often feel very isolated, alone, unheard. They don't understand why. And maybe they're not very sure of treatment options. So I care about talking about this because I believe women deserve to age well and to have the full life that they deserve, and they can live their truth. And as I thought about this last night, I remembered a story. So for a long time, I was on Fox 17, a local TV station, every week. And I talked about different health events every week for 5 or 6 years. And as a result of that, a lot of times I would meet people in the community that I had never met and was lucky enough to have touched their lives. And I'll never forget, I was walking downtown Grand Rapids and I was crossing a street. And it was at dusk and there weren't many people around. And I'm walking across the street and I heard out of a car this voice that said, "Doctor, doctor." And, you know, I kind of turned and looked, and this woman said, "Are you Dr. Bitner?" And I said, "Yes." And she said, "I can't thank you enough." And I was so blessed as she told me her story. What had happened is she heard me talking about pelvic pain on TV, and she was home, not working at the time, and she was suffering from chronic pelvic pain. She had such terrible periods. She maybe had one good week a month. And so she was telling me this from her car at the stoplight. And she said, "You said in the TV broadcast that women deserved to have treatment. They didn't have to suffer in silence. And therefore," she said, "I called my doctor and I said, please, you need to figure this out because I can't work, I can't function, I had children to support, and I need to get this figured out." And she said, "If you don't, I know Dr. Bitner will, so please help me." So she really owned her power and she found her voice, and she ended up having surgery for a large uterine fibroid. She had some scar tissue. She had a hysterectomy. She said, "I bought this car because I was able to get my life back. We fixed the pelvic pain and I was able to get my life back. And I was able to get a job. I was able to buy a car, and I can support my children." I mean, doesn't that say it right there? So again, I'm so glad that she stopped me in the middle of the street. And that just goes to show how much pelvic pain can affect one's life. So what I want to do is just talk about 4 common causes of pelvic pain, and then we'll just kind of see where our time is. And I've got a whole list of things that I could talk about. These are, of course, compiled from working in women's health and OBGYN for over 26 years. And when I was doing general OBGYN, of course, this was multiple patients every day. And of course, those were just the patients that were coming to see me, right? So how many women out there are suffering and never getting help? Again, that just makes me crazy. So one of the first things I want to talk about is endometriosis. And whenever we talk about a condition such as endometriosis, I think one of the best treatments is for a woman just to know exactly what's going on and to understand, you know, exactly what's happening and what the problem is in terms of then thinking about treatment solutions. So endometriosis. In medicine, we name a lot of things Latin names. I don't know if it just makes us, you know, feel smart, but basically these words just describe the tissue and where it comes from and what it does. So endo means inside. Metria means uterus in Latin, and osis means So what I want you to think about is the lining of the uterus is like your lawn, right? It's like the grass outside. And the lining of the uterus is called the endometrium. So endometrium, the lining for the uterus, can go outside of the uterus. So pretend you're mowing your lawn, you mow the grass, and little bits of grass go flying everywhere. Some might go on the sidewalk, it plants in the cracks and it grows. That's endometriosis. So tissue from the inside of the uterus escapes to the outside of the uterus and it grows in places that it doesn't belong. And we know that every woman, every month that she has a period, some of this tissue will escape out through the tubes. We know that for some women, it can go through the lymph system, maybe some even through the blood vessel system. But for most, it goes out the tubes. Now, if most women have that tissue go out the tubes every month, why doesn't everybody have endometriosis? We know that for most women, that tissue goes outside of the tube, and the body's immune system recognizes that the tissue is in a place that it doesn't belong. And so little Pac-Man cells come along and eat it up, and it gets taken, into the liver and the poop, and it gets taken out of the body. But for some women, the immune system does not recognize it as foreign, so it lets it grow. And there's different kinds of endometriosis, some that grows just on the surface, some that it's like the tip of the iceberg. You see the endometriosis, when you look inside with a camera, but there's a big iceberg of endometriosis underneath the visible tip. And so what happens is that these women can have deep infiltrating endometriosis that goes down below those tissues. And endometriosis is sticky and it's like rubber cement. So for example, if a woman has endometriosis that goes out the tube and it goes to the ovary, it can make the tube stick to the ovary. And that can cause, for example, infertility because the tube is stuck and it's not open to pick up an egg so it can be fertilized so someone can get pregnant. So it can cause scar tissue between, let's say, the ovary and the uterus, or the tube and the uterus, or the tube and the bowel. So in the pelvis, the uterus is sitting there, the tube's on the side, and the ovaries on the side of the uterus. And of course, the bowel is sitting on top, the bladder's in the front, the rectum's in the back. So everything is all in the bowl of the pelvis. And so endometriosis is this tissue that doesn't belong there, that acts like rubber cement. And what it does is it creates an inflammatory response. And so what does that mean? When you have, let's say, a sprained knee, you fall down, you sprain your knee. That damaged tissue releases inflammatory factors. And those inflammatory factors, CRP, IL-6, those inflammatory factors cause the blood vessels to be leaky, so you can get a little bit of swelling. It causes a lot of growth factors to come, and so new blood vessels grow. It feeds the endometriosis. So basically, there's this inflammatory response that makes you feel like you've got a swollen, sprained pelvis. Now, for some women, there's just a little bit of endometriosis, and it might cause a lot of pain. It might cause a little pain, but essentially, it's kind of like everything can flare up right before a regular period. Why does that happen? Again, this is tissue from the inside of the uterus, and what feeds it? Estrogen. So as that estrogen level is real high around ovulation and just after, it feeds this tissue to grow just like the inside of the uterus. And so this tissue grows, the inflammatory response is more. And so some women have pain starting at ovulation when that estrogen peaks until through the period. And as the period goes down, maybe the pain goes down. And so I'm looking to see Maria. I'm very interested in this topic, but out walking. So great, Maria. Hopefully you can catch the replay. So endometriosis makes this inflammatory response. And again, it can cause a lot of pain. Now, if some women have so much endometriosis that everything is stuck, there might not be as much pain. If people have just a couple spots or a couple bunches of endometriosis, it might cause more pain because of, again, who knows if it's the rubbing or if it's just the response, the inflammatory response. When women have endometriosis, it can also cause that inflammatory response. Endometrial tissue releases prostaglandins. Prostaglandins can make you cramp, so you have more cramping with your period, but also can make your bowel cramp. So a lot of times women with endometriosis have diarrhea, have constipation, have just a lot of bowel pain, which can be lower left side, that happens right around the time of a period. So again, this might sound like a lot, but it's not rocket science. It's just this inflammatory response. And I'm just giving you the names of the inflammatory chemicals that make all this response happen. Bottom line, it can be normal to have a lot of pain and even bowel symptoms. What is a treatment? Number one, the treatment could be the birth control pill, which can help suppress some of the endometriosis by just stopping the ups and downs of the ovary making estrogen and just give a little bit every day. And the synthetic progesterone in the birth control pill can be suppressive to the endometriosis. It doesn't work for everybody. Sometimes an IUD in the uterus can help because it suppresses the endometrium, the lining of the uterus, so there's not a lot, we think, to spread anymore. But also that local progesterone effect can be very effective to suppress that endometriosis. For some women, it's truly blocking estrogen with, let's say, Lupron or Lupron. It's a shot, and what it does is it lowers the body estrogen to the point where it doesn't stimulate the growth. Unfortunately, with Lupron, there's a lot of side effects. There's new medications that are coming out all the time. So again, see your gynecologist and make sure that you're getting the latest treatment. For some women, it's necessary to do a surgery called a laparoscopy, which just means we look inside the belly with a camera. And so we see this endometriosis. Now, back in the day when we didn't really have a sense that it would go deep underneath, we just thought we could kind of burn it with a little Bernie stick and call it a day. And now we know that in many women, that's not effective. It's really important to have removal of the endometriosis tissue to really have good response. And sometimes the endometriosis is really close to organs that we don't want to damage with surgery. The endometriosis can be close to, let's say, the iliac artery, the iliac vein. Those are big blood vessels in the side of the pelvis that most gynecologists really like to stay away from. So the other organ that can be around, or the structure, is the ureter. It's the tube that connects the kidney to the bladder. And so if the endometriosis is around the ureter, then it can cause pain with, as the urine comes down. It can even cause blockage of urine in some people and hurt the kidneys. For some women, it can be really close to, let's say, the bowel. So, of course, using a Bernie stick on the bowel is not acceptable. It's not safe. It can cause a hole in the bowel. So it's really important to have a surgeon who's comfortable removing endometriosis when it's close to really important structures that are important not to damage. So if you choose to seek care for endometriosis and surgery is part of it, I really want you to own your power, own your voice, and ask the difficult questions. Are you good at this? Are you trained at this? What if we have a complication with a bowel injury or a bladder injury? What are you going to do about it? And, are you comfortable removing stage 2, stage 3, or stage 4 endometriosis? And how many cases like this have you done? So there are surgeons who very specifically specialize in this, and they're called the minimally invasive gynecologists. So there are doctors, again, who are listed on websites. We can certainly get you those names, but those are people who are specialized in removing that endometriosis to really give the very best result. So again, own your power and make sure that you speak up. And again, there are many treatment options. To diagnose endometriosis, it's a diagnosis of really understanding your story. So again, when you go in for an appointment, make sure you've got the details, when it happens, what makes it better, what makes it worse, what you've tried, and make sure that really we put together the story. The definitive diagnosis of endometriosis is having a laparoscopy or a scope and a camera through the belly button to look and see if you actually have endometriosis. And a lot of times we can just treat with a birth control pill or the IUD and just see how it goes. And again, if the symptoms don't get better, then maybe it's time for surgery. So just make sure you've got informed consent and you do not suffer and you get answers. So that's endometriosis. So hopefully I didn't ramble too much. I could talk about this all night, just endometriosis. So again, please own your power and know this. So the second thing we'll talk about are just painful periods. So the fancy word for painful periods is dysmenorrhea. Dys means painful or icky or bad. Menorrhea means the event of having a period. So again, I want you to remember, what is the tissue called inside the uterus? Endometrium. So what happens to have a period is that your ovaries make your hormones, estrogen and progesterone. Again, think of the lining of the uterus like your lawn. And so every month your ovary makes estrogen, which is fertilizer, and progesterone, which is weed killer. And those hormones together make that lining of the uterus grow. So it's nice and thick and lush and ready for a fertilized egg to plant and a baby to grow. If a woman is not pregnant, then the message isn't there that there's a pregnancy started. Excuse me. And so what happens is those cells in the ovary die, hormone levels fall, and the lining is shed. So part of that process is that the lining of the uterus, the endometrium, can make something called, again, prostaglandins. We talked about that with endometriosis. Prostaglandins, are those hormone chemicals that let the blood vessels swell and get a little leaky in the wall of the uterus. Now, all of that response is necessary for a pregnancy to happen. So when it's just in the little right amount for pregnancy to happen, prostaglandins are good. But some women just make a lot of prostaglandins and they have more of an inflammatory response. Maybe they have a little higher estrogen. We know that women who carry extra weight, they store extra estrogen, and maybe that leads to a higher response. But what happens is that those prostaglandins can really cause the uterus to cramp. They can cause the bowels to cramp, again, with diarrhea, constipation, and just real crampy bowels that just create this whole swollen mess in the pelvis right around the time of a period. So painful periods can mean that something is going on, let's say endometriosis. Let's say that they can be worse if a woman has uterine fibroids, which are benign tumors of the wall of the uterus. Because what do fibroids make? Prostaglandins. Again, the same thing that is found in a swollen knee, a swollen pelvis. It's the same kind of thing. Think about what is Motrin or ibuprofen or naproxen or any of those non-steroidal pain medicines. What are they? You got it. They are anti-prostaglandins. So if you have painful periods, the first step is just to think about, okay, number one, why? Probably nothing wrong. Number two, if you can start the Aleve, the Motrin, the ibuprofen, whatever brand you like, if you can start that medicine a day or two before you know the period's going to start, it can actually reduce the pain with the period, especially, again, if you get started earlier, and it can even reduce how much blood you lose or how heavy your period is by reducing those prostaglandins. Another common condition that causes painful periods is something called adenomyosis. Again, back to the Latin thing. A-D-E-N-O. Adeno means gland. Thanks, Missy. So adenomyosis. So the glands grow in the wall of the uterus. And so adenomyosis is almost like, think about it like you're having a period in the wall of your uterus. How awful does that sound? Because that tissue doesn't like to stretch. But essentially, these glands are in the wall of your uterus. This happens more maybe if you've had lots of babies or a twin pregnancy where that uterus gets really stretched, but I've definitely seen it in women who have never had children. Adenomyosis can even be in a bunch of glands. We call it an adenomyoma. Basically, it means a bunch of glands stuck in the wall of the uterus. Again, what does that do? It creates a lot of inflammatory response and, again, just really painful periods. How do you diagnose it? Somewhat diagnosis of exclusion. Get an ultrasound of the pelvis, make sure there's nothing else going on, track it with your history, and then again, we try some options. Number one, we can start with a non-steroidal like Motrin, and there can be really strong prescription non-steroidals we can use for pain, but also potentially a birth control pill, potentially an IUD that contains progesterone. Again, what is progesterone? Weed killer. So if we can put weed killer in the wall of the uterus, that can even settle down adenomyosis. And for example, women after maybe they have 2, 3, 4 babies, they have adenomyosis, they have painful periods, they're 40, they still want to have some birth control. An IUD that contains progesterone would be a great option for everything. I'll never forget, I had a patient who had adenomyosis. We put in an IUD. She did not want a hysterectomy no matter what. She had terrible pain and bleeding. And she said, okay, I'll give it 2 months. She still was having pain. 3 months, 4 months. She finally stopped having periods after having that IUD in her uterus, probably 10 months, that she finally had resolution of her symptoms. And again, we had done a DNC, we had done an ultrasound, we made sure there was nothing wrong, there was no cancer, but she just had these painful, irregular periods. And the IUD took like 10 months to work. But I think we finally even scheduled the hysterectomy, and she called and said, oh my gosh, I had a month with no bleeding. So we canceled the hysterectomy and called it an honor, a winning treat. I'm seeing a question from Penny Johnson. Dr. Bitner, I had 2 removals of endometriosis many years ago. I've also had a partial hysterectomy. Is it possible that the past endometriosis was not completely removed to still cause pelvic pain? So Penny, yes, and especially if you had a partial hysterectomy, I'm assuming what you mean is that your ovaries are still in place. So even if you had a little bit of endometriosis left, what can happen is that you still were making your estrogen, your progesterone, and so you could have potentially even growth of what little bit of endometriosis was left, especially if you have had endometriosis that was sort of underneath the surface, that was kind of hiding. I remember I had a patient who I did a partial hysterectomy. In fact, I took out her uterus, I left her cervix, and she had a little bit of endometriosis still that grew back on the top of the cervix on the inside of the pelvis, and she had bowel that stuck to that. And so we went back in, we had to, cut the scar tissue and then remove that last little bit of endometriosis, took out her cervix, and at that time decided to take out her ovaries, left her without hormones for a bit, and then treated the surgical menopause with hormone replacement therapy. So again, see a specialist that can help with this. An ultrasound could tell us if there's a bunch of endometriosis, like a ball of endometriosis. We call that an endometrioma. But otherwise, it's on physical exam, it's by diagnosis of exclusion, and potentially a laparoscopy or trying different medications. But to answer your question, yes, it could be residual endometriosis, and I would recommend you see a specialist. And Dixie, thank you for your comment. That's it, Diana. Can you forward this information to me on endometriosis? So Dixie, happy to send you the link later of this, and let me know, Dixie's an great family friend. So Dixie, just text me later and let me know more what you might want to know on this. So endometriosis we talked about, painful periods we talked about. Also want to talk about high tone pelvic floor dysfunction. So this is something that I've learned about in the last couple of years. I wish I had known it my entire career. I think of all the women that came to see me for pelvic pain, we did everything to rule out bad stuff. So for example, even to the point of doing a laparoscopy, a surgery to look inside for endometriosis. Nope, no endometriosis. Didn't really go along with, let's say, irritable bowel syndrome or, constipation, diarrhea. Wasn't that. We did CAT scans, we did MRIs, we did, tons of studies to understand what the pelvic pain was. And basically I would say, I don't know why you have pelvic pain. Then it was all the rage, interstitial cystitis, which we believe does exist. But once we knew that we had another condition that could potentially explain people's problems, we would talk about interstitial cystitis. Everybody's got interstitial cystitis. Some women would get better with, let's say, putting some steroid in the bladder or doing a procedure where it would fill the bladder really full and stretch it. And sometimes these women would get better. But just now that we really know so much more about high tone pelvic floor dysfunction, it just makes sense. I first learned about pelvic floor dysfunction at ISWISH. ISWISH is the International Society for the Study of Women's Sexual Health. And learning about why women have pelvic pain, we used to call it vaginismus or pelvic pain with intercourse, then it really started to make sense that the pelvic muscles can react to lifestyles such as too much Pilates. And so it's really important to understand this. So how I want to explain is that the pelvis is like a bowl. So the bones of the pelvis make a bowl. And I want you to think about between the pelvic bones, it's like an open hole, essentially. And so what happens is that there's like a trampoline or a floor on the pelvis, because if it wasn't there, if we stood up, all our stuff would fall out. So we have 3 holes in the floor. We have 1 hole for the bladder, 1 hole for the vagina, and 1 hole for the rectum. And so these holes or openings have muscles around them called sphincters. And so as we become potty trained when we're little, we learn how to control these muscles. We learn how to open them when we want, and we close them when we don't want things to come out. So those muscles we're able to control. But the rest of the muscles are smooth muscles. We don't have voluntary control. And so these muscles are across the pelvic floor. And then these muscles connect up to our belly muscles. So like our rectus abdominis, so our muscles, our obliques, the muscles that go across in our belly. They hook up into the hip muscles. They hook up into the muscles in our back. They go down into our quads. They go down into our hamstrings. And so these pelvic floor muscles have a lot of work to do. So again, they have to keep stuff in when we need it in, and they have to let stuff out when we want it to come out. So there's a lot of connections that happen in these muscles. One thing that I think about that's a really common way to think about is that if you sit a lot, let's say at a desk, or you drive a car a lot, you travel, a lot of times our hips and our pelvis get tight. So think about it like our pelvis rotates in, our hips rotate in, and those muscles get so tight that when we want to stretch, it feels real tight, and we feel like we've got bladder pressure maybe because our bladder can't expand because our pelvic muscles are pushing on the bladder. We might have like issues with having rectal urgency, where all of a sudden the BM will just come out without any control. Let's say you go for a run, you're starting to rev up, you're getting your muscles contracting, and then all of a sudden you're looking for a spot in the woods to go have a BM. More of you have that than you'll ever tell me, but it's not an uncommon thing that we might have rectal urgency or bladder urgency because of that high tone pelvic floor dysfunction. When those muscles are tight and it can feel achy, it can feel pressury or throbby, especially let's say you just get out of the car after a long car trip, or let's say you've exercised a lot and you haven't stretched. This high tone pelvic floor dysfunction can really interfere, again, with bladder function, bowel function, but also, let's say, penetrative intercourse. So if you have intercourse and you feel like your partner is hitting the wall, that's because those muscles are just spasming down and saying, please don't come in here. It's too tight and that hurts. And so this high tone pelvic floor dysfunction is way more common than we ever thought. Again, it can really explain pelvic pain. And it's very treatable. So for example, if a woman tells me about this on exam, I can even feel inside a vaginal exam. So I'll, feel inside to her pelvis, and the muscles will feel very tight and tender. And again, I'm not a pelvic floor physical therapist, but at least we can get a good sense. Even sometimes I'll take a woman's leg and move her hip in and out, and you can feel those muscles spasm, and it will really show her that is a big cause of her pelvic pain. To treat the pelvic pain from high-tone pelvic floor dysfunction, we have pelvic floor physical therapists. And for example, iMove Physical Therapy has a room in our office at True Women's Health, and we're so blessed to have Kara there, who's a functional physical therapist, but also trained in pelvic floor. And so she's able to help work with women in terms of having good core strength, good back strength for good posture and good alignment, but then also working manually to get joints and all that in order, and helping to teach women to be able to relax those pelvic floor muscles. Again, we want to keep things tight so we don't leak urine, but also to make sure they're not too tight. So therefore we can not have pain from that tight pelvic floor. For example, I've also have patients who have had endometriosis, and they've had surgery for endometriosis, and just that scar tissue or just having had that surgery can create a response where those muscles are just extra tight in the pelvis. So again, many of these conditions, one thing affects the other. I had a woman with a very large uterus with uterine fibroids, and that heavy uterus sat on the muscles in the pelvis, and it created this whole situation where the pelvic floor muscle was spasming in reaction to the uterine fibroids. And again, it created this whole dysfunction. And once we took out her uterus for the fibroids, she still had that leftover pelvic pain, which then we were able to help her resolve with pelvic floor physical therapy. What can also happen is that we can use a medicine like Valium that helps those muscles relax, that a woman can use even a Valium pill in her vagina before intercourse or after pain or after therapy, just in just a little bit in the beginning to help resolve that pain and really help her feel control of the situation. So again, this high-tone pelvic floor dysfunction, I wish I had known about it years ago, and it's really allowed me to help a lot of my patients. Another condition I want to talk about, I'm looking at time. I can't believe it's already half an hour. The other condition we hear a lot about is irritable bowel syndrome. So irritable bowel syndrome is just what it sounds like. Our bowels are irritable. And sometimes when the bowels become so irritable, women develop constipation, or they'll develop diarrhea, or they will develop a combination of both that's associated with pain that lasts for on and off more than 6 months. So irritable bowel syndrome can really interfere with life. Of course, constipation can lead to cramping, can lead to bloating, and really leave people very uncomfortable. Diarrhea, of course, who wants to deal with loose stool, especially if you're in a meeting or you're working, or who wants to deal with running to the bathroom? And of course, irritable bowel syndrome, we know, can be associated with anxiety, with depression. And it's not so much that someone's depressed about the pain or has pain, so therefore they're depressed, although, of course, that vicious cycle can happen. But we know that irritable bowel syndrome can also be related to brain chemical levels such as serotonin. So again, it's not just a brain chemical, it's a neurotransmitter. It's a chemical that helps nerves talk to each other. And for example, we know that with young children, for example, they can have what's called an abdominal migraine, which is a condition that's often associated with chronic stress, unresolved stress, which leads to belly pain, which is likely a form of irritable bowel. So irritable bowel, again, diagnosis of exclusion. If I'm concerned or a woman has danger signs, then of course we're going to make sure with ultrasounds, with CAT scans, to make sure there's no mass, there's no cancer. Of course, if there's any concern or a woman's the appropriate age or family history, definitely a colonoscopy, an upper scope to make sure that there's no cancer, there's no precancer, there's no what's called diverticulosis or itis, little pockets off the colon wall. So again, diagnosis of exclusion then leads us to irritable bowel syndrome. We know, for example, that, thankfully with more knowledge from functional medicine, we're learning more and more about the importance of bacteria in the bowel. So it's so important in that large colon that we have a really healthy community of good, healthy bacteria in the colon. And just by taking a fermented food such as kombucha or kimchi or sauerkraut, whatever works for you. I do 1/3 of a bottle of GT kombucha every day. And that helps keep that healthy bacteria. So it's having that probiotic bacteria. It's having prebiotic fiber. Let's just say even just an apple a day has inulin, has a really healthy fiber. So just to start with irritable bowel, make sure you're getting enough prebiotic fiber, including apples, a probiotic bacteria, kombucha, and then really studying your symptoms. Certain medications can help as you're figuring this out, medications that help stop the bowel from spasming. But also sometimes it can be helpful if we think it's related to serotonin, especially let's say it's cyclical. It can relate to your period serotonin or even those prostaglandins again. Again, as you can see, there's so many factors that interact. I don't want to just keep listing off all these things, but that's how we have to think about this. We have to be Sherlock Holmes and really, again, understand your history and your cycles and what's going on. And again, these are probably the 4 most common conditions that we see. Briefly, at least I want to discuss the concern of ovarian cancer, for example. So ovarian cancer is one of those cancers that can be really hard to diagnose. It's a cancer that usually isn't diagnosed until a woman is later along in the process. Of course, there's different stages of ovarian cancer, starting from stage 1 to stage 4. Ovarian cancer tends to, we think, start in the end of the fallopian tube or the shell of the ovary, and it starts in the ovary. Now, we have a lot of room in our pelvis, and so there can be a lot of room for, let's say, a growth or a tumor to be there. And the symptoms of ovarian cancer can be very vague. Now, ovarian cancer can happen more often if a woman has a family history of ovarian cancer. And so if you have a family history or if you are of Jewish descent, and it's more likely that you carry the BRCA1 or the BRCA2 gene, it can be very important to get genetic testing. And so again, don't be afraid to ask. At True, we do genetic testing, and a lot of my colleagues across the country do as well. So don't be afraid to ask for that. But in terms of the symptoms, I just want to share with you my 10-day rule. A lot of us gynecologists have this rule. If a symptom lasts for more than 10 days, ask for help, ask to get help figuring this out. The symptoms of ovarian cancer, again, can be very vague. I don't know about you, but us girls can tend to blow stuff off because we're too busy. We don't want to bug anyone, and we don't have time to go get an ultrasound. So if you have symptoms that come and go, diarrhea, constipation, pelvic pain, a little something, if it comes and goes, it maybe isn't something bad. If it persists, you've got to get checked out. And often all it takes is an ultrasound of the pelvis. We can see if the ovaries are normal, make sure there's not a mass in the pelvis, and we can make sure that we get this figured out. Now, sometimes with pelvic exam, even if I know a woman has a mass on her ovary, we can't always feel it on pelvic exam. So pelvic exams are very important to get at least once a year. But if you have pain and your pelvic exam was normal, push the envelope, ask for help, ask for an ultrasound, make sure you get checked out. Unfortunately, with ovarian cancer, there is no way at this time that we have a good screening tool. There's not a blood test. There's not a practice of getting, let's say, regular ultrasounds. That just isn't a great screening tool. So it's on us to be really aware, know your risk factors, and if you have persistent pain, make sure that you be seen by a physician or a healthcare provider that knows what they're doing in terms of women's health, and get an ultrasound or a test. So again, we could talk all night about several other things like ovarian cysts and pelvic inflammatory disease. I'm looking at my list just to make sure I don't forget uterine fibroids, ovarian tumors or torsion. So there's lots of things that can cause pelvic pain. But bottom line, what I want you to take away from this is if you have pain, do not suffer in silence. So as we always wrap these Let's Chats up, let's first start with 5 takeaway tips. So tip number 1 is know your phase of ovarian function. If you're in menopause, you're not going to have painful periods. You're not likely going to be stimulating endometriosis. So if you're in menopause, it's probably not that. So again, we've got to be Sherlock Holmes. We've got to figure stuff out. If you're in perimenopause, now this is a time where your periods might be irregular. You might have a month of hot flashes and then a month of not, and a month of yes and a month of no. So what happens in perimenopause is we get these big bursts of estrogen and then drops, and big bursts and drops. So like all those things that we talked about, endometriosis, uterine fibroids, these conditions will grow with big bursts of estrogen. So a lot of times in perimenopause, the symptoms of endometriosis, adenomyosis, uterine fibroids, the symptoms will get worse. So it's important to know your phase of ovarian function to help us figure out what's going on. Okay, so know your phase. Number 2, track your menstrual cycles. So there are now apps. Of course, there's an app for most things, right? So there are apps that you can track your periods. And many of my patients will come in and they've got their period tracker app going and they track their periods. And it really is helpful. And then a lot of these apps, you can make notes when you had pain. If you had more pain with intercourse, did you have more pressure in your bladder, more pressure in your rectum? You had maybe some bladder urgency, some leaking. You had some nausea, some diarrhea, some constipation. Track your cycles and track your symptoms. Number 3, exactly that. Track your pain. So did the pain get better with a BM? Did it get worse right before you had a BM? Does it get worse when your bladder is full? Does it get worse when you empty your bladder? So these are really important things to track your pain. Did it get better when you took Motrin 2 days before your period or not? Did it get worse when you ate certain foods? So does it worse when you stretch? Is it worse when you drive in the car a long time? So track your pain, make notes, because when you go into your doctor, you might not get a lot of time. You got to come prepared. So come with your list of questions, track your pain, send the doctor an email before you see them. So you can right away make sure that they're prepared and they can help you and be really efficient. So question number 4, know what makes your pain better or worse. So again, what activity, bowel or bladder functions, intercourse, or pain medicines. So this is really important to know. And also know your family history. Did your mom deal with this? Did your aunt deal with this? So it's really important to have a sense of your family history. Okay, tip number 5, do not stop until you get answers. And again, it took that one woman to hear me talk on TV to go to her doctor and own her power and find her voice. So do not stop until you have answers. So healthcare providers, nurse midwives, nurse practitioners, PAs, physicians, those that are trained in women's health can really help get to the bottom of this. And again, it starts with a good history, a good exam, maybe an ultrasound. And again, we can figure this out. Do not suffer. And now I'd like to offer 5 questions to be ready to ask your healthcare provider. So question number 1, what is your expertise or training in pelvic pain? For us healthcare providers, it's hard to know everything about everything. And sometimes it's hard for us to say we don't know because we like to fix stuff. We want to be there for you. And so no disrespect to providers. If they say, well, it's this and you don't get better, it's okay to say, what is your training? Thank you for your help initially, but I need more expertise. It's really important that we don't just, for example, jump to a surgery. So I've had younger patients who were offered a surgery right away without even trying a birth control pill, without trying an IUD. Let's rule out endometriosis when in fact it was high tone pelvic floor dysfunction, and it was not endometriosis. So it's really important to ask, what is your expertise? And then if a provider offers a surgery, for example, ask the questions. How do I know you're good? What is your complication rate? How many surgeries like this do you do? So it's really important to speak up for yourself and ask these questions. Question number 2, I want you to say, can we talk about the details of my pain? Sometimes you have to slow people down and say, look, I really want to understand. I only get you for 10 or 20 minutes. I need to know what's going on. Can we really talk about these details? And again, if it's a provider that doesn't know maybe what to do with some of those details, ask for a referral to someone who might know more. Question number 3, how are we going to figure out the cause of my pain, and what are we going to do? So for example, if an ultrasound is ordered, how is that going to help us? How is that going to help us figure out what it is? Maybe it's just to rule out bad stuff, and then we can kind of start with some of the basic treatment. But it's really important, again, I want you to be informed, so you ask those good questions and you make sure and get the answers. Is it a blood test? Is it a CAT scan? What is it, and what are we going to do with that information? Especially if surgery is part of what's offered for diagnosis. Question number 4, what are my options to feel better? I feel so strongly about something we call informed consent. So whenever we offer a treatment, I think it's really important as healthcare providers that we do not tell you what to do. We're not your boss. We're not your mom. We're not here to just tell you what to do. It's really important. So I tell my patients all the time, I don't have ego invested in what you do, but I have a lot of ego invested in that you know your options that are safe for you. So for pelvic pain, there might be 4 options for what the provider thinks that is going on. So it's important to talk about the pros and cons and risks of each, starting with the least invasive, let's say observe, let's say healthy lifestyle, let's say probiotics and prebiotics and pelvic floor physical therapy. So we start with the least invasive and we go up to the most invasive, let's say a hysterectomy. So it's really important to start with the least and go to the most. And it's often just so awesome that we can usually get good relief with just starting with the basics. And so again, know your options and the pros and cons and risks and benefits of each of those, including cost, including recovery, including risk. Okay, question number 5, what are the side effects and consequences? So again, if it's a birth control, what are the risks? If it's an IUD, what are the pros and cons and risks? If it's a surgery, we don't want to just jump to surgery. Sometimes it comes to that, but what are the pros and cons? So again, I just find that so many times people think, oh, the doctor said, so we're just going to do it. No, ask questions. And there are lots of different options, and it never hurts to ask for a second opinion. When patients would ask me, hey, doc, can I have a second opinion before that surgery? I'd be like, awesome, because maybe we'll both learn something. And if another opinion of someone I respect says the same thing, that makes me feel really good. If another doc says, hey, what about this? Let's think about this. Isn't that great that now we have more information and we have 2 sets of brains that are looking at the same problem? So if a doctor is offended by you asking about a second opinion, that's a red flag. Make sure that you ask, it's okay to get a second opinion. So again, having said this will be on the website. If you have a friend that has any of these conditions and you think this information would be helpful, please share this with them. We just so wanted to have this in the library that we could refer patients to say, again, if nothing else, knowledge is power. Know what you have, know why you have it, and ask the hard questions to get help when you need it. Knowledge is power. Suffering is not necessary. Please take care, own your power, and stay safe. And please visit us at truewomenshealth.com. Thank you very much.